medical care as well as testing. The fact that the patient receives an agreement that clearly states that this is not insurance because it confines only to care and arrangement between a patient and a doctor, and it helps the patient who does not have insurance or has a very high deductible. There were some concerns about it. We have worked with the department, and it's only a matter of clarification. There is no substantive change in the bill as we are presenting it.
Thank you for the explanation. Representative Clemens, you're recognized.
Thank you, Mr. Chairman. Representative Kumar, I appreciate the intent of this bill. I think the intent of this bill might be better served if we were to pass Insure Tennessee to provide access to quality, affordable health care to these individuals. And I can't get past where there's an expectation of a certain level of coverage. I know that you're talking about introducing an agreement for a specified set or a sum, but this is in my mind, definition of insurance. And to specifically state that it's not is a sincere concern of mine, and I think the expectation of the patients who would take advantage of this type of thing, while well-intended, might not receive the proper care or the amount of care that they're expecting when they enter into this type of agreement. And again, I just don't see how this does not qualify as insurance or fall under that code, other than the fact that you're trying to expressly prohibit it from being considered such. So as I've discussed, I'll have to vote against this, but if you want to address any of those points, I'd appreciate it. If not, thank you, Mr. Chairman.
Well, certainly, I would like to clarify again, it is not insurance because it does not meet the requirements for insurance. It is a private arrangement where a patient is paying a prepaid retainer. If you were to consider this insurance, you will also have to consider concierge care as insurance. There are certain requirements that insurance policy meets. Patient clearly understand it's not insurance in the sense that a patient cannot go to another doctor and expect the doctor who took the payment to pay for that. It does not. The amount of care is also well specified. The number of visits, amount of blood testing available are well defined, and it's a very compassionate thing for a physician to do, and I think it frees the physician from having to bill the insurance companies and lowers the cost for that patient.
Representative Hill, you're recognized.
Can you come back to?
Yeah, you like to withdraw that motion?
Yes, I withdraw that motion.
Without objection. Representative Favors, you're recognized.
Okay, thank you, Mr. Chairman. Last week when this was introduced, I looked at it and have since read about it and tried to understand it fully before I could support or oppose it. But is there anyone here from insurance department that could explain this more fully, and if there are any concerns? Because this is something that's unusual. However, a physician can set a price now. You don't have to have legislation to do that. If a physician says, I'll see you for $35, they already can do that.
All right.
So is there someone here?
Yeah, I think we can, Representative Favors. Okay. Members, without objection, we will go out of session.
Thank you.
Please come forward and state your name for the record, and be happy to hear from you. Thank you
Sure.
very much.
Michael Humphreys, I'm the Assistant Commissioner of the Insurance Division. Kathleen Dixon is one of our Assistant General Counsels. Initially, when the bill was introduced, we did have some concerns. We're right now at a working with sponsor posture. We've met a few times with Representative Kumar, and we've suggested some amendatory language to build in some disclosures that we think add an element of consumer protection to this arrangement that's essentially an agreement between an individual and a primary care physician for some services as defined in whatever that contract may be with the physician's office surrounding preventative care services. Our amendments would require in both marketing material and in the agreement itself that disclosures including that the agreement does not constitute health insurance, that an uninsured patient that enters into a direct primary care membership agreement may still be subject to tax penalties under the Affordable Care Act for not having insurance, and that patients insured by ACA compliant plans will already have coverage for many preventative care benefits at no additional cost to that patient. The ACA sets out, I think there's probably 10 pages of preventative care benefits that must be covered at no cost to those that have an ACA compliant insurance plan. And just skimming off the top, those would include blood pressure screenings, cholesterol screenings, depression screenings, immunizations, your well visits, your annual physicals. For women that are pregnant or may become pregnant, it includes breastfeeding support and counseling, gestational diabetes screening. It includes breast cancer genetic test counseling, breast cancer mammography screening, cervical cancer screenings, and for children it includes all sorts of behavioral assessments that are all covered at no cost to those that are insured. So when we had initially raised some concerns with Representative Kumar, the concerns were that someone purchasing this product or agreement may not fully understand the coverage that they may already have, and that it may not be, in fact, a benefit for many of those individuals that already have ACA compliant coverage.
Okay.
Representative Favors, you're recognized.
Yes, thank you. Thank you for that explanation. But in your mandatory language, is there any oversight for this product?
No,
With
Representative
current
Favors.
insurance plans you do, so there's no oversight.
It would not be subject to Title 56 like another insurance company would.
So a provider could do pretty much what they please.
There's no review of the provider agreement. Like in the case of an insurance company, the forms and rates get filed with our department. We review them to make sure the rates are adequate for the benefits provided. That's not in this bill.
So that's a concern of mine, sir, that there would not be any oversight. And thinking about the consumer, that's my primary concern. I'm hoping that they would understand this, so that's why I don't think, until I see some mandatory language that I'm comfortable with, I just can't support this. And my colleagues, I think we have to be sure that there is some oversight for this product. Thank you.
Thank you, Representative Favors. My question to you is there's other entities out there right now that are doing boutique medicine or VIP, so forth, that deals with more access than it does services. Is that accurate?
As we understand, there may be concierge practices. We don't have direct knowledge of one that may be operating because they wouldn't be coming to this department, but we've not had a complaint that we needed to investigate to look at a boutique firm like that.
Okay. So, but this one, can you explain a little bit how this works? They sign up for a monthly payment that is in a range or uncapped, or they come to some sort of agreement? Is the monthly fee capped in this, or could it be anything?
Not under the legislation. I think that's something that would be negotiated with the primary care physician's office.
Okay, so it would be uncapped. And then the other thing is they're providing all those services for free, and then they could negotiate a fee schedule based on other things they provide, potentially outside of that scope of all those laboratory tests that they're doing?
I think there's language in the bill that should there be additional visits, you could in theory cap it to 5 visits, and any additional visits on top of that, there would be a separate fee for those additional visits. I think the bill caps the cost for those additional visits to no more than what would be the cost of the membership fee for a monthly basis. So if you had to pay for visit 5 through 10 out of pocket, those visits couldn't cost more than the monthly fee, which we understand is usually somewhere around $50 to $70.
Right. That's usually the case, but there's nothing that keeps them from raising that fee to
That's correct.
to 100, 200, or whatever dollar amount that they so choose, right? And then if there's something that's not in the agreement that they cover by that monthly fee, then they could bill the insurance to pay those things. Is that accurate?
That I don't know that is accurate under the proposed rule or the legislation, because I think there's a provision in here that says in the agreement any direct primary care will not bill third parties on a fee-for-service basis. So I think in theory the physician could give an individual member information that the individual member could then go back and try to file with the insurance carrier. that may be a challenging process.
So if these physicians are their primary care physician, right, and they do anything out of scope of those laboratory tests or the well visits or that sort of stuff, if they need to do more than that for that primary care patient, they can't do that because they can't bill insurance, or would the patient have to pay for that?
Well, I don't know that anything would prohibit that, except that, I mean, in this agreement and in this bill, it's limited to primary care services. So if they needed to go above and beyond that, I think that would be outside the scope of the agreement.
Okay. Representative Kumar, you're recognized.
Yeah, thank you. I would like to cover these points that have been raised. One, it will be a monthly fee, and for that fee, a person has clearly signed an agreement that says that they can get so many visits during the year and so many blood tests done. If additional services become necessary, it makes sense that the physician or the care provider will tell the patient, you need this more, this is what it's going to cost. So it would be very clear, and there is nothing vague about it. There is no oversight necessary because it is not insurance. So insurance laws do not apply, and that is the very purpose of this bill, to give the people or empower the physician and the patient to for the patient to receive care from a physician for a small monthly fee. Because they cannot afford insurance. If they could afford insurance, then certainly they would be getting their coverage under insurance. If they have a high deductible, even then this works as a mini health savings account, so to speak, that they can get coverage for high deductible insurance for their primary care needs. Filing of insurance is really up to the physician, in the sense that for these services that are either patient has no insurance, so there is nothing to file. If they do have insurance, in that situation, if it is a high deductible, and we are talking about care provided for about $600 or $800 for the year, whereas the deductible is $5,000, it's irrelevant. A patient can, in case they have a catastrophic accident and feel that they had paid $600 towards their medical care during the year, and they would like for it to be counted towards their deductible, they can collect a receipt and file with the insurance company themselves. Regarding preventive care, when a patient buys insurance, they would be aware enough to know what their insurance covers. So if they know that certain preventive services are available under their insurance, they would use their insurance, and I would think be encouraged by the primary care practice to do that. Again, I think it empowers people who cannot afford insurance, allows them to have a private arrangement with their physician, and we would like to keep insurance regulations definitely out of that. Thank you.
Representative Williams, recognized.
Dr. Kumar, so if I know we're out of session, should I ask one now? Dr. Kumar, should someone go to the doctor one time and they had this physician and they paid $50 a month, based on what we're talking about today, that's $600. That's $600 for one office visit. If they don't do any lab work or anything like that, they just do all that. Are you saying that someone can turn in a $600 office visit on their insurance?
I don't think there is anything like a $600 visit. I don't think a patient is going to pay $600.
Well, it's not that there is a visit. It's that what they've paid is $600, and they've gotten that. But it's my understanding that the fee was separate than the other. It's for membership, and with that membership, you get certain privileges, which means seeing your doctor. But if you're going to turn that in insurance to your insurance to meet a deductible over a period of time, and you only go one time, but my question is, how would you turn a monthly fee in with insurance?
It makes no economic sense for a patient to sign up for paying $50 a month if they're going to need the doctor only once a year. And this is a low-income patient who doesn't have that much money, and they cannot afford insurance. This is for a person with a chronic condition that they know they will use services to a degree that $600 a year or $50 a month will be justified. And that is a patient with diabetes, hypertension, or other chronic condition for which they know that if they do not sign up with this, doctor's visit is really not $50 anymore, it's at least $80 to $100. But for paying $50 on a regular basis, they get so many visits a year. That's who this is for. This is not for a person who's going to see the doctor once a year.
Okay, I'm just trying to, whether they go one time or, I mean, if they win as many as 4 times, you're still, my concern is that you're still wanting to turn that into insurance when my understanding is that we weren't trying to turn this into insurance. But if you went to the doctor and he said you need to go have an MRI, and then your insurance came in and stepped in to do that, and you went somewhere else, then that itself could be a cost that would go towards deductible, be turned into your primary care insurance with whoever it is.
Let us take the situation of a person that has a $3,000 deductible. They have diabetes, they're buying their supplies, and managing the best they can, or they're basically taking medication for it that is not covered because the deductible is too high. But they need regular checkup to have their blood sugar checked and the diabetes education and other things that they need. For $49 a month, they are getting this care. And they are seeing the doctor once a month. So really, economic sense for this arrangement will be at least you're seeing the doctor 6, 8, or 10 times a year. That is the only scenario under which it will make economic sense. And I think patients know that if they're going to spend that type of money. Supposing that patient then goes on, unfortunately has a bad accident or needs an MRI, as you said. So now it's time to, it is necessary to use insurance. Question is, can they, the amount that they paid towards the care, can they claim that towards their deductible? It will depend on the physician's ability to file it for them. It will depend on the insurance company, how they take, if the physician tries, if the patient tries to file it privately. It will depend on that. But again, sincerely, the reason for this legislation is to allow a patient that does not have insurance to pay a small monthly fee, receive care for their chronic condition, not for a single visit.
Department, quick question. Is there anything in this bill that limits it to chronic care? Is it open to anybody?
It would be open to anybody. The bill would limit it to primary care services, but anybody with or without insurance could, in theory, negotiate.
Right, so it could be anybody who wants to enter into this contract can do it, whether they have chronic or acute or whatever.
Yes, sir.
It may be. And then you could have insurance or not have insurance. It doesn't specify which direction it could go.
That's right. And the one thing that we would add on the deductible portion, to your chairman, or to your question, Mr. Chairman, the membership fee is not going to count towards your deductible. $600, $700 a year. You're not going to submit that to the carrier, and the carrier is going to say, okay, that counts towards your deductible. Whether some paid services that would extend beyond those free services that you would have. In theory, if someone were to submit those to a carrier with CPT codes, I guess in theory a carrier may consider applying those towards a deductible, but they may not also.
Representative Williams, you're recognized.
The question is this is about insurance or it's not about insurance? It can't be about both and then say it's not about insurance. You see what I'm saying? So, and I think the doctor is sincere when he says this has nothing to do with insurance, but in fact, if you're submitting claims towards something and calling it a compensating care or some kind of care, then eventually somebody's going to turn something into insurance, and then I just don't know how. I don't know how we remedy that. But I appreciate you saying that. Chairman Sexton, I think there's someone else in the committee. I don't know if you've noticed that would like to discuss. Maybe you can bring some information to mind.
Representative Armstrong, you have a... Okay, that's fine. Representative Armstrong, you're recognized.
Thank you, Mr. Chairman. I know that there are other programs that provide health care that aren't that don't fall in the insurance realm. Healthcare sharing ministries are one that, but that's recognized by the Affordable Care Act as being an exemption.
For purposes of the individual mandate only.
Right, for the individual mandate. Does this in any way would satisfy that individual mandate under the Affordable Care Act?
No, and that's why we had suggested one of those disclosures to suggest that.
Okay. Does this set up a new? Is this creating a network, or would it be looked upon as a MCO, or how would, let's say, the Mennonites that are in Tennessee, how they share each other's medical bills? How does the department view that particular ministry, or that particular sharing of health care bills? Do you look at it as charity, or do you look at it as a exempt form of insurance? How do you look at that?
We would look at direct primary care as distinct from healthcare sharing ministries. It's simply the agreement between the individual and the physician's office. We work with Representative Kumar's office on trying to limit the scope on, I think there's a definition, or an affiliate is within the definitions. We think that the language as it was before we suggested some amendments may be broad enough that in theory you could cross the line into being more towards a network MCO-like system, but on its face, and I think the intent is just to be primarily me to my primary care physician rather than any affiliates or referrals within that system that would not be covered under this fee.
And if a person is eligible for Medicare, which, under Medicare now, routine physicals and things like that are currently covered under that. Where would, in Medicare, it would be the last resort for reimbursement, or how would this fit into that reimbursement? Would this be considered as a medical expense in any kind of form, whether it was looked at it from as TennCare or Medicare expense for someone?
Well, we don't, the Medicare piece for senior citizens, obviously separate from the TennCare piece, we don't regulate the Medicare program. That's primarily at the federal level. There may be, there's language in this bill about being open to the Medicare program. We don't know enough about how the Medicare program operates to know what may be permissible or not, other than Medicare has given guidance that where the program requires patients to pay co-pays for services, the physicians are generally required to collect that money from your patients. Routinely waiving these co-pays could implicate anti-kickback statutes, and you may not advertise that you will forgive co-payments. I don't know if direct primary care.
What about TennCare? What about TennCare then? Are the same requirements pretty much mirrored in your?
I can't speak for the TennCare program.
TennCare, okay. TennCare or Medicaid, whichever.
Yeah, we can't speak to the regulation of the TennCare program. I'm not sure how this would work within the TennCare system, if at all.
Any more questions? Seeing none, thank you. Appreciate that. And Beacon Center, Lindsay, just state your name for the record, and if you have a statement, or we can start asking questions, however you want to do it.
Sure. Thank you, Chairman. My name is Lindsay Boyd. I'm the Policy Director at the Beacon Center, and I just have a brief clarifying statement, and then I'm happy to take any questions, because I think there's been a little bit of a misintroduction of this bill, and I think by simply clarifying something, we can quickly move on. Direct primary care is currently in practice in Tennessee as drafted under this legislation. This legislation only seeks to close a loophole that exists right now in Tennessee law that could subject direct primary care physicians to being regulated as insurers. Direct primary care is very similar in concept to concierge medicine. And so it would simply protect direct primary care physicians currently practicing and those who wish to practice in the state from being regulated as insurers. There is no ability for a physician under this agreement to ever bill any insurance for any services provided under this agreement. The provider cannot bill the insurance, the patient can also not bill the insurance. It's meant to help patients who either have a high deductible insurance plan that because of that high deductible they've not used their insurance for 2 or 3 years. It's meant to give them another form of accessing care at an affordable rate while they maintain coverage and have coverage for catastrophic care. They satisfy their individual mandate and so forth. Or for those individuals who may have such low income that they are exempted from that individual mandate and want to be able to afford some quality primary care. So this just simply closes a legal loophole that right now subjects physicians across the state to being regulated as insurers. This just closes that loophole. It's very simple, actually.
Representative Williams, you recognize.
As you know, up here, the simple stuff are never simple. But I did have a quick question for you. Let's say Dr. Sexton signs me up. I do a $600 a year deal. How? And he bolts, and I got nothing. How? What's the remedy for somebody? Do you call? Does that person have to call the board of medical examiners and turn them in, or do they call? Who? How do you get your money back, or how do you do that?
Well, first of all, the arrangement is paid on a monthly basis. It can never be paid a year in advance. That's one way that it separates itself from insurance. So it's a monthly fee. It's paid per month. So there's no advance payment except for maybe 1 month's advance payment. The physicians are still under licensure requirements by the state. They still must be good practitioners and good actors. So if they were to violate the agreement, they are subjected to every legal ramification that a current physician would be subjected to if they broke their Hippocratic code.
So if I have someone who claims to be a physician, claims to be a physician, they're selling this premium. How do I check? How do I, as a consumer, check to make sure they're actually who they say they are?
Well, they must be a licensed primary care physician in the state of Tennessee. So it's just like any other provider you'd be looking or shopping around for. You would do the same sort of due diligence as you would when you're changing physicians now.
There's an inferred. I've been seeing the same primary care guy for 15 years, but I've never seen his degree. You know, I go to a medical office building and you see there, I know where he went to school now, but when I first went there, I don't think I did. It's my understanding these people may or may not be in an office setting. If they're concierge medicine, they might operate out of their home and go visit people at their house. I mean, how would somebody check that?
They do operate in a clinical setting. These are family practitioners. They do operate in clinics, many times with nurses on staff. There are 6 current primary care clinics across the state seeing patients. About 4,000 patients across the state of Tennessee now currently are seeking primary care through these physicians, and they are they are regulated and reviewed by the medical boards of the state. So they're still subjected to the same quality standards that every other physician in the state is. And as you suggested, just because you don't see a degree on a wall doesn't mean that they're not a licensed physician. That standard that exists for all of our physicians, and I have actually participated in this program in the past, is the same standard for all.
Thank you.
The question I have, and this goes back to what Chairman Williams was saying, was about, you said the payments are month to month, but the bill says that the patient's not required to pay more than 12 months of the fee in advance.
Yes, that's correct. They pay per month, usually at the end of every month, and they cannot pay for a year in advance. It must be billed on a monthly basis.
I understand what you're saying, but it doesn't. I don't think legal's agreeing that this limits it to a month-to-month basis. I think it does allow somebody to pay the full 12 months up front. There's nothing in here that says that it's a month-to-month capability, which may be the intent we understand the intent, but we're not sure that the language actually infers that it's a month-to-month payment.
It's my understanding that in the legislation it does state that it is a flat monthly fee.
Okay, Jess, you're recognized.
I'm just looking at the definition of the direct primary care agreement, and it's one of the components of that definition is that it's a written contractual agreement between a primary care provider and the patient, in which, and G is the patient is not required to pay more than 12 months of the fee in advance. So that would, to me, read that you could be asked to pay a year in advance, more than a year in advance, but 12 months in advance.
That is not allowed in the current contractual agreements for direct primary care physicians. There are 12 states that currently have this legislation in place, and there are 17 other states currently considering this legislation and pending passage. And this is the language that has been passed in all 12 of those states. The regulations that oversee the contractual agreements would be something that the Tennessee Medical Board would oversee, and in those contracts it is a month-to-month payment, but I'm sure that the sponsor may want to consider just tightening up that language if that would make the committee more comfortable. That would be a question for him.
Jess, you have a comment?
I think if you want to limit it to month by month, that the bill needs to be amended, because right now the language reads to me that it allows you to do a year in advance.
Thank you, Mr.
Representative
Chairman.
Kumar.
I think the process is working well. This is the purpose of making legislation, and I respect your indulgence. Certainly, as I've spoken to the chairman before the committee hearing, that some clarification amendment is in progress and will be placed before the bill reaches the full committee, and we will definitely do that. The intent is not to allow a patient to be charged ahead of time, so we will make the adjustment to the language. If that is possible, I would be thankful.
All right, Representative Kumar, before we do that, is there any more questions for Ms. Boyd? Seeing none, thank you, Ms. Boyd, for testifying. Without objection, we're back in session. Representative Williams, you're recognized.
Chairman Sexton, I understand you got the gavel at this point, but it is with great pride that I say that I do not send bills out of here knowing that we're going to verbally amend them, or we know that there's a problem with them. I'm not in support of, even though we deliberated on this at great length, I would say, because I have one technical amendment already that I've filed in order to try to improve this bill, I would say that this bill, that the committee process is good to help improve a bill, but I'm not in support of moving a bill just so that we can change it when we know it's not right now. It's not like we don't have time in order to fix it in the committee. So my suggestion is either to take the bill off notice or roll if it hasn't rolled a week to the committee members.
Representative Hill.
Parliamentary inquiry, Mr. Chairman.
That'd be me.
Parliamentary inquiry. Since we have debated this bill for a really long time, and we know what the sponsor's intention is to fix it, are we within the purview of this subcommittee to make that technical change now?
Representative Hill, to go to your question, if it was merely a technical change, that might be something, but I think you've heard from the Department of Commerce and Insurance that they have a consumer amendment, protection amendments that they like to put on this bill.
They said they didn't want to come back next week, so we should just go ahead and pass it.
Right.
That's what
But theoretically, they have amendments that does consumer protections.
Okay.
You have a technical amendment, which I understand in that, but then you also have the payment thing, which is a little bit more than technical.
Okay. Thank you.
You're welcome. Representative Kumar, how about this? The bill's been rolled 1 week to keep it from being rolled a second time, to protect that second roll. Can we take it off notice and then you put it back on notice next week? No harm, no foul.
I'm thankful for the committee's help, and thank you, Mr. Chairman.
All right, thank you.
We'd be
And then
happy
we'll
to do
get
that.
with the committee and everybody and make sure we get this thing right before next week. With that, House Bill 2323 is off notice. Chairman Williams, you are recognized.